I've been a practicing women's health internist for the last 30 years. And just recently, probably in the sixth segment of my professional career, I launched a company called Ms.Medicine. The mission and vision of Ms.Medicine is to raise the standard of care in women's health, specifically gender-specific primary care. And you might ask, why do we need that? Well, I can tell you from 30 years of clinical experience and from being actively involved in the North American Menopause Society for the last 20 years and for being in different healthcare arenas over the course of my career, academics and private practice, employed, independent, and watching what's happening with healthcare reform and changes in reimbursement and really the rapidly escalating cost of healthcare. I've seen a lot, and I have really, I believe, some insight into a big problem, which is that women are not getting adequate gender-specific primary care in many arenas, but specifically in menopause management, female sexual dysfunction, cancer survivorship, breast cancer risk assessment and prevention, bone health, and I could go on and on. And you might ask, why is that? Well, I can tell you there's several reasons. It's not just one reason. One of the reasons is that currently the employed healthcare delivery model, where most primary care providers are employed by health systems, that is not conducive to providing comprehensive women's primary care. And you might ask, what does that mean and why? Well, typically now for employed primary care providers, they're required, based on their compensation models, most of them are RVU models, to see 28 patients a day. The average primary care provider is spending 7 minutes with a patient. And I can tell you, as a primary care provider who was an employed physician and who was trying to provide midlife women's health care in that model, it's impossible. So the average primary care provider has 7 minutes with a patient, and I can tell you in 7 minutes what's happening is we are trying to do the most acute problem and do damage control, and we have diabetes and hypertension and congestive heart failure and COPD to manage. And I can tell you menopause management and those scary hormones and, gosh forbid, sexual health really gets neglected. There's no time for it. And not only is there no time for it, unfortunately, in the way that we train and educate primary care providers, they simply don't get enough primary care, women's health primary care education. They really don't get enough menopause education. They don't get sexual medicine training. And as a result, they get out in practice, and I know this as well too as a practicing internist, you do things that you know well, that you feel very qualified to take care of. And in the arenas of menopause, particularly as the data with the Women's Health Initiative came out and was very scary for most primary care providers, even though that was a long time ago now, the damage of that still is that internists tend to be afraid of hormones. They certainly don't want to prescribe them. And they're really not interested or trained in helping women with sexual dysfunction. So as a result, women at the age of menopause fall in this void. So the OBGYNs are very comfortable being primary care providers for young reproductive age women, and they do a great job at that. The truth is, there's too few of them in number compared to primary care providers, and they don't really have experience in or training in more complex internal medicine diseases. And so when patients become 45 and 48 and 50, it's difficult for OBGYNs to remain complete primary care providers because that's when women start having problems, but with other illnesses. And so again, the primary care providers need to fill the gap, and yet they're not trained and they don't have the time to do so. So what happens to women? All of these issues that are time-consuming and complex, they simply don't get addressed. And so what happens is many women find the way to alternative type practices or to supplements or to now the new rage is online telemedicine for hormones, all of which I think I have concerns about. And so really, Ms.Medicine, and again, back to my mission vision is to raise the standard of gender-specific women's primary care And what that means is the company's all about building a practice model that allows clinicians the opportunity, once they're trained and educated, to provide high quality, gender-specific women's primary care, longitudinal care over time, and to meet the unmet needs. So this is, again, doing breast cancer risk assessment and prevention, managing menopause in an evidence-based way, addressing sexual health concerns, managing cancer survivors, all things that right now really aren't happening adequately in traditional primary care practices. And again, it's nobody's fault. I have been there, an employed physician seeing 28 patients a day with documentation requirements on the electronic health record. It's impossible to do high quality, gender-specific primary care. Hence, Ms.Medicine. So if you'd like to learn more, please reach out, contact us as a patient or as a clinician. The goal is to grow Ms.Medicine across the US.